Welcome to Global Health Dialogues. Today's guest is not your typical pharmaceutical executive. He's not here to talk about molecules in labs or markets in charts. He's here to remind us that innovation only matters if it reaches the people who need it most. Dr. Michael Oberreiter is the head of External Affairs International at Roche, one of the world's leading biotech companies. But more than that, he's an impactful architect of health equity, working tirelessly behind the scenes to change how the world thinks about access. From the remote clinics of Kenya to policy tables in Tbilisi, from city cancer partnerships to groundbreaking insurance collaborations, Dr. Michael has helped reshape not just how we treat cancer, but how we fund it, value it, and deliver it. And he's here today to talk about the stories, the strategies, and the hope that drives his work. Dr. Michael, I've read that you once worked in a bookshop, quite a world away from global health policy. How can you take us on that career journey? How did you go from selling books to leading global access at one of the world's biggest healthcare companies?
Oh, thank you, Princess Dina. First of all, thank you for the really marvelous introduction. And I want to start with nothing I do alone. So I'm highly dependent and grateful for having the opportunity to work with amazing global leaders like you and the others you mentioned, the City Council Challenge. So the bookstore story is actually not that far away from global health, because I think we would all agree if you look at the social determinants of health. So those factors who actually are defining if we're living a healthy life or not, there's actually a key pillar of it is actually education. So the bookstore was actually, I would say, it was almost like my place. I come from a family with a rather simple background. So no one ever before me went to university, but I had a grandmother. So it's almost, if I also look at global health, not to underestimate the role that women play, not only when it comes to global health, but also when it comes to education. So it was my grandmother who instilled almost the hunger for education and the love for books in me. And I was working in a bookstore, had an own little bookstore in Vienna at the time. And one of my clients actually worked in the Minister of Health in Austria. So I had a lot of conversations during the time in the bookstore. And she really asked me, like, don't you want to do more than just selling books? And so she helped me to get a scholarship, went to evening school. I graduated then with international economics. And my first job straight right after the bookstore was actually for a generic company, where my job was increasing access to affordable medicines. And since then, this was almost 30 years ago, that was sort of like the story of my life, that I always spent my time in the pharmaceutical industry around the topic of access, policy, equitable access, health literacy, education.
But what an amazing story. One, it really piqued my interest because I'm a grandma already. I have
I have to stop here and interrupt you. Unbelievable. No one would believe that. But it's older.
I am a very happy and proud grandma to Thuraya, who is 1 year, 8 months now. And there's another one coming this month. We're waiting. We're in a waiting game right now. And I absolutely love your story, how much your grandma influenced your life. And I hope I will do the same. So I'm on it. I'm on it, Michael. I'm going to read lots of books and give her all that I have to empower my little grandchild. That brings me to, you've mentioned that your work as, you talked about access, and you have a big important title. You are the head of external affairs at Roche. Big title to speak about. And really, that means you are the go-to person for access at Roche. Very powerful title. At a time when access to treatment now is under such enormous pressure from aging populations, rising communicable diseases, shortage of healthcare workers, how do you facilitate access to those who need it most? In layman terms, Michael,
So
tell
really,
us, what does your
yeah.
job actually entail?
So my job actually at the core of this is, first of all, an acknowledgement that what you just mentioned, those three big trends, which we, by the way, we have known for years, right? We do know since years ago that by 2050, 1 in 6 people will be over 60 years old. And if I look, which means if you would go into a bus in 2050, it's just like every sixth person will be over 60 years old. I mean, you are going to be one of them. I'm going to be one of them. We also know when it comes particularly to cancer care, that the majority of cancer cases, almost like 60% of cancer cases, and unfortunately 70% of cancer deaths, are also occurring in the age sort of like over 65 around it.
Yes.
So we know that strain. So we have the aging society and it's here. Then we also know what you mentioned rightly is at the same time we have a serious problem with workforce. And that's actually a global problem that we are facing, because there's not a single healthcare system in the whole world where you could sort of like have enough nurses within your country. So what we are seeing happening right now is that richer countries actually importing doctors and nurses and healthcare professionals from poorer countries to fulfill the needs of their population. But inadvertently, by doing so, we create a big problem for those poorer countries around it. And with aging and having less of a working population, financing, which has always been an issue, has become even more a bigger issue. So my role as the head of external affairs is actually really connecting and almost like trying to be a bridge builder and a catalyst, bringing the right people around the table and working on common solutions. And it could be people from the private sector, governments, NGOs, experts from academia.
Fantastic. And you know, this problem about let's say, the immigration of healthcare workers from low middle income countries to high income countries, this happens to us here in Jordan, because Jordan, we have a really good healthcare workforce. And of course, you know, attracted to better pay, let's say in the Gulf countries, they leave in droves. And we constantly have to graduate more and more. And I know that this is happening worldwide as well. Michael, you're really passionate about making the case for investing in healthcare and have spoken about the fact that innovation does save lives, particularly with cancer, where unfortunately it is still seen as just a cost rather than an investment. And logic says that. And of course, we've all been saying that. And the NCD community have also been saying that. But to be frank, when these innovative drugs are so costly and beyond many governments' budgets, it can all seem so academic and abstract. Please tell us about how you backed up your statement with real data and made it make sense.
So really thank you for giving me this opportunity. And I think the interesting thing is we're very much focused on how expensive quality healthcare is. And we are completely ignoring that by not investing into quality care, we are paying and already paying for not investing in that space. And I give you one number, and it's not a Roche number, it's not a number from me, it's a number from the Harvard University that was presented by the World Economic Forum. And they looked at the top 5 non-communicable diseases, which would be cardiovascular diseases, cancer care, diabetes, neurological conditions, and respiratory diseases. Only those 5 diseases at the global scale, until 2030, they cost us an amount of 47 trillion US dollar. And I looked it up, like, how can you explain what are 47 trillion US dollars? That would be enough money to hand every single person around the planet an envelope with 6,000 US dollars and say, Go and do whatever you want. And it would be enough money to send every child that is born today and it's around the bank. It would be enough money to send every single child around the world to university and finance their studies, and they don't have to pay anything for it. So we are already paying. So in my opinion, I try to make the cases. This is not enough, sort of like about like, can we afford to do it? Can we afford to pay for quality care? The more important question is, how long can we afford not to invest into quality care? And so what we have done is, and this is really a big pledge I'm making to anyone who is an advocate or interested in that space, is we need to become better in understanding sort of like how does the brain of a policymaker work around that. And I'm not blaming a health minister here, but a health minister has a budget for 12 months, right? So, and their budget usually is based on the money they did get the year before. So we also need to help policymakers to make the investment case. And if I may, one example from a country which is sort of like in the Arabic world, which I love a lot, is the government in Egypt decided in 2019 to address breast cancer in Egypt. So they started a presidential campaign because a lot of women in Egypt showed up and were diagnosed at a stage 3 or even a stage 4. And unfortunately, we know there's not that much you can do in the late stage. So they did start a public campaign for educating women, go to early screening programs. And they collected the data over 3 years from that program. And at the end of 2022, when they finished the first wave of screening and women who did get access to treatment, they found out that for each Egyptian pound invested in early screening, in early diagnosis, and in early treatment, the return of investment was almost 1.40 Egyptian pound, which means a 40% return of investment on a public policy intervention. And I think this is the examples and this is the language we need to start to use more often. So we really need to be very clear that cancer care, it's not a cost. If you want to have thriving economies, we need to address the cancer burden, and it's actually an investment for the government. Not only for the Minister of Health, we also need to speak with the Minister of Finance, the Minister of Education, the Minister of Economic Affairs, and simply need to show them the data and the evidence.
Yeah, and what you said is absolutely true. And I read somewhere you actually even did some real data with the HER2 cancer treatments about how much it brings back for the GDP. Can you tell us about that study?
So we did a study. So we work with an independent academic institution. What's also very important in that space is that we have close relationships. And this is where my job is sort of like the bridge builder. So an independent academic institution with a scientifically proven methodology. And they did look only at the HER2, which is one of the most prominent breast cancer types we are all facing. And they looked at it sort of like, what can you generate by improving access to those therapies, which means actually as a first step, improving screening, improving access to diagnostics, and then of course, access to medicines. And we calculated the number only for the biggest economies in the world, the top 10 economies in the world. And the number that came out was it's an $8 billion contribution to the GDP. And this has nothing to do with if it's a Roche product or not. This is true for interventions in cancer care and all. So we can make really a strong investment case that if you improve cancer care, if you improve access to diagnostics, if you improve patient pathways, and if you improve the whole surrounding ecosystem, you do not improve the life of a single person. You also help to have a healthier population, and you actively contribute to economic growth. And this is honestly the number one topic that every government has currently on their agenda.
So this is what you have said is absolutely makes sense. Logic says it makes sense. But this brings me to how you make it happen in real life. Your work in Georgia, in Tbilisi, you managed to persuade the government to include diagnostic tests
Yeah.
into their universal health coverage plans. How did you achieve this? I know that this is huge. In my own country, even we do not have that. And before you answer, I just want to give my viewers some background. Cancer treatment for those countries who have proper national cancer plans, they usually cover, of course, cancer treatment, but they don't cover diagnostic tests that tell you what kind of cancer it is or how to treat it more often than not. And that means patients may get free chemotherapy, for example, but cannot afford the tests that decide if it's even the right one. So you helped change that in Georgia by making sure diagnostics are reimbursed just like treatment. Did Roche actually donate these tests? Did you lower prices? What were the foundational elements that were in place that laid the ground for this amazing, successful national partnership?
So thank you so much. And I really think the success really belongs, as often in cancer care, to the people on the ground. And who are those people on the ground? And that, I think, it's the first key to success. Acknowledge no one of us can solve this challenge or address this problem alone. So it is an element of humbleness to say, like, as a first step, is you need to look who are the people you need to sit around the table. So the first step actually for success was building a strong coalition. It was not even a public-private partnership then. It was a coalition of the willing, of people and experts who understand and are willing, let's address this problem together. So the first piece was this coalition of the willing. This is something we need to address. What was in parallel very, very important is really generating the data and the evidence to help to make the case in the very specific local context. We have gazillion and millions of data out there, like all those global data, but it doesn't help me if I'm in a country or if I'm in a province. So there was an element of really generating very specific data, sort of like for Georgia. And then also, strong recommendation, strong learning is, it needs to be a system, or it needs to be a solution that is really accepted and embedded into the local system. So what's not working is sort of like an individual company developing a solution and then try to go in a country. This was really right from the beginning a co-creation. And there were doctors and nurses and politicians and caregivers and patients around a table equally represented, which I think it's the gold standard in developing cancer policies, that you should have all the constituents, so all the people who are impacted by the policy that you're doing really, really around the table. And once we had and then the third key magic ingredient is actually, can we agree what is the outcome we want to achieve? Can we have clarity? And interestingly, our experience is, once you align behind what is the shared objective, the shared goal we want to achieve, then you can find a solution. So it was really create a coalition of the willing, make sure you make decisions or you discuss topic based on local data and on local evidence around that. Make sure everybody around the table has an equal share of voice and align behind the shared outcomes. And then once we had those shared outcomes, we could really work on concrete solutions that are working in the context of Georgia, or frankly speaking, in the context of any other countries around it. And that's also the thing, because you asked about, did we lower the prices?
Yes.
My experience, and I'm doing this almost 30 years right now, the usual to-go move would be, if you want to improve cancer care, just lower the prices for diagnostics or for oncology. That doesn't work in oncology because you need nurses, doctors, patients. And I know you know all of this, right? So you need to have a whole infrastructure around it. So if you want to improve patient access, you need to find a balance between, yes, addressing affordability, but also creating this ecosystem. And again, also in Georgia, we went back to making the investment case and showcasing the government. By doing so, this is the return of investment you can achieve.
Yeah. But so if I want to unpack what you said, number one, local ownership. You spoke the importance of local ownership, and I attest to that. I mean, that was certainly our experience in Jordan when we fixed our cancer care here in Jordan. Local ownership was key. But also, I think when you spoke about aligning with one plan, because that's ultimately what you're saying. First of all, you said everybody was represented, all the stakeholders on one table, and having that one plan at city level or country level that you could align with, that made all the difference. And I think that did your partnership with City Cancer Challenge helped with that, right? Because that's what they do normally. They are the ones, I mean, the model of City Cancer Challenge is that in a way, shall we say, they establish the managerial infrastructure on the ground. Did you work with them on that?
Yeah,
Or
so absolutely all the credits for, and I think so they have a City Council Challenge, which is this independent NGO based in Geneva, but working around the globe. They are really excellent in creating this platform where you get the public and the private sector together, and they have a process behind it. So they do a very proper due diligence process. So due diligence is kind of like you really and sort of like you evaluate upfront, sort of like what are the risks and opportunities, and you be very clear on what can you bring to the table. So what is actually also the qualification, or what part of problem solving can you do, and what can you not do? Because you are not qualified, you don't have the experience around it. So having someone like City Council Challenge, who is like independent and neutral, is really crucial in order to facilitate the whole discussion and actually also driving things forward.
yeah, fantastic. But I still want to ask you, how did you make it affordable? Even if you had everybody on the table and there were many, I agree with you. You need a comprehensive thinking about how
Yeah.
to solve the problem. We know that. So you have the part of the infrastructure on the ground. You have the issue of human resources, and you have the issue of money. How did you make it more affordable? How did you
So
manage to do that?
So what we did is we designed together with the partners, we really decided an offering or packages that would work in the local system and the local context of Georgia. Like there's always a misconception when it comes to pharma. Again, I have to re-emphasize this over and over again. In the absence of having diagnostics in place, a clear patient pathway, a referral pathway, qualified nurses, qualified doctors, lowering the prices does not help because the drug will still not reach the patient. But once you build that and you can guarantee the drug can reach the patient, then we're going to negotiate with the local government and we find a solution. And this is exactly what we did with Georgia. And we have been very transparent right from the start. So what was also clear in the process for this project is like, I'm not advocating for better access to diagnostics, so including diagnostics in your benefit package for your patients, and they're not offering you something on the end. But in the absence of having diagnosis included in patient pathways, there is not much I can offer you because it will not make a difference. And
Yes.
we have this saying in Roche, which is like our core mantra is innovation is useless if it doesn't reach the people who need it. So
Yes.
that's the core principle we follow through in any project that we are doing.
But you spoke about blended finance. I mean, did you
Yeah.
do some kind of blended finance with this? Because, how did Georgia
So
suddenly come up with the
interestingly,
extra money? Mm.
so the blended financing, and I'm coming back a little bit, is linked to this investment case. So the interesting thing is every government around the world can tell me what they spent, right?
Yes.
They spent, but they cannot tell me what they're not getting back in terms of investment by not treating patients, because
Yeah.
it's a very short term. You might not feel it in your budget, but then a woman you do not diagnose early with a breast cancer is a woman that will come back in 3, 4, or 5 years from now at the late stage. And we
Yes.
all know the late stages are the most expensive one.
Yes.
So this whole blended financing models, that's going to be something that will become more and more important in the future. And we have anecdotal evidence. So there are projects. We did actually in Dubai, we created a health insurance package for foreign workers that would give them some cancer care insurance coverage. Not foreign workers who are coming in there around it. But blended financing is for sure, and I know you are also like quite aware of that. That's going to be one of the key future topics, particularly now that we are living in a world. I mean, it's 2025. We know that major global donors are pulling out there. And we also know if you look at all global donor money into global health, it's a marginal percentage that goes into non-communicable diseases, and it's a marginal percentage that goes into cancer care.
Yeah.
So this is definitely a topic of the future where we need to look at alternative financing models for cancer care.
Yeah. Innovation. I mean, I saw one of your quotes that we need innovation in financial architecture as well. And I agree with you totally in that. And I didn't know that Roche was behind that coverage for the expat workers, because I had heard about this fantastic plan. Well done. And now this, shifting gears, your program in Rwanda. One always often hears that fixing cancer care in low resource settings takes billions. But in Kigali, a simple idea quietly changed everything. You actually helped shorten the duration between diagnosis and treatment for a very sizable number of patients. Can you tell us about that?
So I always like to do a little bit of myth busting, in this topic. So there is actually, particularly in low resource settings or countries, when you look at implementing cancer care, the advantage is, if I would look at richer countries or Western European countries, you're talking about systems that were evolved over like decades of years with all its complexities. So yes, while you have all those challenges in like low resource settings, you also have all those opportunities. So what many do not know is, for example, Rwanda was one of the first countries who made a couple of years ago as a goal for the government, we want to become and create the first digitalized healthcare system in the world. So they are actually quite affluent in digital and technology around that. And that is a huge benefit. Like the key challenge I think we are facing in cancer care, it's the same thing I faced when I started in this role or like in the pharma industry 30 years ago. It's usually delayed diagnosis, right? That people showing up way too late. It's always inequitable access, which means your postal code still decides if you get the right treatment at the right time, if you're getting diagnosed, which is true in every single country around the world. And then it's this topic of financial toxicity. But what has fundamentally changed is we have innovation everywhere. And it's not only in the drug space where we made huge progress around that, or the diagnostic space where you can even now detect cancer in the earliest signals before the disease sort of like is already prevalent or has broken out there. But we also have the big power now to use technology to closing the gaps and addressing healthcare workers. And in Rwanda, in a country where actually healthcare, credits to the government, has been acknowledged, if you want to have economic growth, you need to have a robust and resilient and a stable healthcare system. There was a partnership, and it was with using roles like patient navigators who would help a patient to navigate the complexity of the system, bringing in some digital tools which are accessible to the population, which actually helps them to navigate. That can tremendously help to speed up things there.
Yeah, and I think just to tell our viewers that before you helped give a solution to the big lag, to get, from diagnosis to treatment as quick as possible. I mean, that's what one hopes for normally. Rwanda used to have maybe 50% of patients able to go through from diagnosis to treatment within 60 days, right? With this little tweak of, what was it, 5 nurse navigators and a low-cost digital tool, you managed to get 92% of patients into treatment within 60 days. And I think what this example shows, yes, money is very important. And yes, we need money to fix a lot of things, but that's not the only thing. We need to also fix processes. We need to fix governance. We need to have plans. Like you also said in many of your quotes, you cannot have fragmented thinking. You have to look at the problem as a whole and make sure where you can streamline, especially processes, it makes a big difference. And I want to really also stress this this concept of patient navigation. A lot of the times you see it in many healthcare, in many countries, where it doesn't make sense, the navigation process for a patient. And when you have somebody actually focusing on that, you can streamline so many things and actually cut costs and make the difficult journey of the cancer patient, especially, a little bit more easier.
And I think what you just said is really makes such a strong case for, if we want to develop sustainable solutions for cancer care, we need to bring all the relevant voices around the table. Because
Yes,
who is the person who knows best about patient navigation? Honestly, it's quite often not the oncologist. It's not the doctor. It's the nurses in the hospital. Because
exactly.
they are spending more time with patients than, the doctor or the oncologist would do around it. And therefore, you need to have the nurses around the table, and you need to listen to the patients. And you also need to listen what they experienced. And I fully agree with you. So we know the data for decades right now. So we know all the money that goes into cancer care or goes into the healthcare system. There's data out there from the WHO. 25% of resources in the healthcare system are wasted. And they're wasted purely based on inefficient processes.
Yeah.
Around that.
And now, I always repeat what the doctor said. Now, delivering healthcare is through a system. It's no longer with the doctor with a black bag coming into your home. The system is what delivers. And you have to have almost a process engineer, right? To look at the systems to make it streamlined and make it efficient and make it make sense. And here I want to, because you mentioned healthcare workers. And I love the fact that there was a quote from you, and I love non-diplomatic people, because I'm one of them, by the way. You said that it's ridiculous what healthcare workers earn. And I love this quote because you don't sugarcoat it, because it's the truth. Why is it? Why do you think the world so easily overlooks the very people who carry its health systems on their backs, and 70% of whom are women? And what would it actually take, not just to pay them fairly, but to respect, protect, and retain them? Tell us about your views on that.
So, just a little bit of background. So I grew up with a single mom and two sisters. So my mom worked as a nurse most of her life, and my two sisters worked as nurses, quit in between, and went back. And the reason they went back is because, so every single person I ever met as a nurse, and that's a little bit part of the problem, he never worked as a nurse because of the salary. They work at nurses because they deeply care for their patients. So, which means they almost willingly accept conditions. Someone who is not so passionate about patients would say, there would be far more of an outcry around that. So I think it's because of, and so when we set the level what a nurse can earn, so all those systems have been created decades ago. We had plenty of nurses. There was no shortage of all of it. It was a very respectable sort of like job to do. But those times have changed. There's not a single country who has not a very strong sort of like a gap in workforce, address the gap. And I think we raised the number already. Assumptions and the numbers differ a little bit. We are talking about 10 million healthcare workers till 2030. So we are falling short of 10 million healthcare workers around the world, and in every single system around that. And I think it's an underappreciation of the qualification of the women, to be very honest, because as you said, it's mostly women in those roles. And I think we need to talk about if our old-fashioned healthcare systems are still equipped to tackle the challenges of the future. Because I know my sisters, based on their their qualification, and they go back to school and they learn every day, they could do way more. But they tell me I cannot. One core element in cancer care is also bringing the cancer care closer to the patients,
Yes.
which again would be, it's going to be the nurse. It's very likely it's not going to be the doctor because we don't have enough of those. So it's rather going to be the nurse who would travel around. And yet they are not allowed to perform, or help patients to the extent they could, because we have just simply old-fashioned rules and regulations. So we need to address those rules and regulations around it.
Yeah.
And then I think we cannot solve the healthcare, sort of like this silent pandemic in NCDs, without talking about healthcare workers. And it has to do with better payment and better working conditions.
But we've been speaking about it for so long. What is it going to make the powers to be? I don't know who they are, to actually acknowledge the importance of the work of healthcare workers and to pay them a living wage, so to speak. It's just so frustrating. I'm a mother of a cancer survivor, and I know very well the importance of nurses. Like you said, you see the doctor maybe once a week or once every 10 days, but it's the nurse that's with you, that knows the family, that knows your child, that stays with you all the time. So, I really sincerely hope that, we thought that COVID was going to give a wake-up call to the world about the importance and the sacrifice of healthcare workers. But I don't see any movement towards bettering the conditions. So I don't know what's going to make that happen, Michael.
So I'm afraid, we all had those high hopes. I think we all witnessed this moment where we said, like, we all remember people on balconies and clapping for healthcare workers. So we all thought about, finally, like, policymakers wake up. They did get the message. Health is an investment. You need to improve working conditions, and healthcare is an investment for economic growth. But we are all human, so this is short-lived. I think I have to come back to, in my experience, if you want to drive sustainable changes, it has to be based on evidence and data. We also need to become better in articulating, yes, there are the healthcare workers who have it in their title and have a professional training. But actually, the unpaid work of women, so what women do who are not nurses around that, the daughter, the spouse, the wife, the aunt, the grandmother, right? So the unpaid work of women in healthcare is what keeps healthcare system going. If every single woman around the world would just drop the ban, every single healthcare system around the world would just crash. And I'm coming back to this fundamental principle as advocates in healthcare. We need to really become better in making the investment case and showcasing, actually, like, we are not here to ask you for a favor. We are key contributors to your economic growth. And if you want to have tax money, sort of like, to benefit and invest for further education, further generations, you better listen to the voices of the women and the private sector and the healthcare workers.
Yeah, I love what you said. We are not asking you for a favor. This is for services rendered, and amazing services rendered as well. I totally agree with that. And now I want to go to talk about your work in Kenya, because through your Roche Empower Clinics, you also reduce the time from diagnostic to treatment from an amazing 18 to 24 months to 3 to 6 months. There must have been many barriers at the time, and this surely required a full-on systems approach. How did you achieve that? And how did you make it financially accessible and affordable?
So again, we knew from the beginning, first of all, I really have to do a big shout out. at the beginning of this idea, we need to do something for women, particularly, and it started actually out for women with breast cancer.
Yeah.
Now it has expanded. So now we're also screening men with prostate cancer, with diabetes. So this idea of how can we reach those women earlier? That was the idea of one woman that happened to work, and she's still working for Roche. So there was one woman. And I have to come back to that. It's amazing what a determined woman can achieve. It was her idea. And she was very clear. She said, like, so I cannot recreate the system. That's impossible, but I need to drive system change. So what I'm going to do is I will go where the patients are going. So instead of designing, somewhere in a beautiful building, a process for where do you have to go as the cancer patients, she really started with observing where are those patients already, or where are those women are already going. And she really noticed they would go to those local medical communities and those medical centers. So she then had this idea of, hey, then let's create something she called Empower Clinics. And just to if you have now in your head the picture of a big hospital and the shiny hospital, no. Empower Clinic started as she went out to the medical communities and said, like, can you give me one room? And I went there, so I saw it was one room, painting with her own hands. And then when women came and were seeking advice around it, offer them the opportunity to get a screening. So one element was really go where patients already are. The second thing is then, okay, so who is going to talk with these women, around breast cancer? And in Kenya, breast cancer is a taboo. You have very few oncologists, and most of them are male. And you would not go as a woman to a male oncologist without your husband, parent, or whatever, because you would not do it culture-wise around it. So she really looked at women at local communities who were, by the way, also looking for a job, and trained them almost like as low-key entry healthcare workers. And we used the power of storytelling. So the good old, in the old days, like sitting around the campfire and telling those stories. So we also used the way of storytelling and building up those Empower Clinics. And which was very, very critical, she got early on the support of the first wives of Africa, which is a very powerful advocacy group of women who are really focusing on women's health. And then, so we started with a room in one medical center, and we collected right from the start the data. And in the beginning, it was not even about the treatment. The first thing was around the early diagnosis and shortening the time to diagnosis. And then we actually used the same principle in Georgia. Once you have an infrastructure, once I have the patients, then I'm going to go in there and then I negotiate with you as a government. And then we will always find a solution. But I cannot lower the prices in the absence of having built the core infrastructure. And what we are particularly proud of, we now have the second version of those Empower Clinics, and they are already supported with digital tools. And it's not fancy digital tools for rich people. It's like tools for the local women around that, where they would get reminder. It could be a WhatsApp, it could be an SMS, help them to navigate those systems.
This is amazing. And, it makes so much sense, especially for women who don't have the time. They don't have in Kenya babysitters, or they're busy cooking and cleaning and taking care of the family. They have no extra time to make that trip to go and be checked. So the fact that you chose the clinics to where they already are, I mean, this is genius and it's logical. And I hope many of our listeners take note, because like you said, so many times they want these shiny, fantastic hospitals where nobody's thinking actually about patient behavior or people's behavior to make sense of what you design around them. I mean, this is absolutely fabulous.
Yeah. And I'm coming back. I mean, you said it so brilliantly right now is, I think the only path forward here in order to really make impact at scale is we need the systems to be designed for the people. We cannot expect people sort of like designing, accommodating their needs to the system. That's just not how healthcare is working around it. And as you said, it doesn't have the big investment. Like that started very small. It was one room. Then we shared the information. Then another medical center came and said, like, I'm interested, I want to have it. So it started really out as one woman, one idea, one room, one tiny clinic, and now it's like 15, 16, and other African countries are looking into it and want to implement the same principle.
And by the way, Michael, if this was a business venture, businesses would have done that, right? They would have done the market analysis. They would have studied the behavior of their customers. And the fact that you added on other screenings, not just for cervical, you added cervical, right? Not just the breast cancer, and you added hypertension and so on. And this is what drives me crazy, actually, is the fact that the healthcare sort of governance around the world, they don't use the business tools that work so well for businesses and brings them profits.
You have been for the longest time such a prominent global advocate around it. So don't you think, I think a little bit the problem here is that healthcare is always associated or one step away from welfare.
Yes.
From welfare. And I really think that is the fundamentally wrong narrative. Because if we really could start to manage, it's like, look, guys, like healthcare, guys and girls. So look, healthcare is one of the core pillar of a robust and a prosperous society. Then we would look those tools, right? Because then we would look at it. How do you properly analyze sort of like a problem? How do you impact? You talk way more about efficiency, which we are shying a little bit.
And KPIs and impact. Yes.
Yeah.
And Michael, this is when I headed the King Hussein Cancer Foundation. When I started establishing in 2002, I understood it had to be run like a business, not the typical charity model. And I called it's a business. I run it like a business, but with a heart. The money that comes from that goes back to be invested in our cancer center. But definitely, I utilized all the tools that businesses do, and I paid money. I wasn't one of those charities that said, oh, by the way, I don't invest anything in marketing, or I don't invest in this. When people used to ask me, oh, you spend money for drivers to pick up your coin collection, for example, boxes. I said, of course I'm going to spend money. What do you expect? Who's going to collect them? Of course, I'm going to spend money for somebody to audit these boxes to make sure that nobody steals them. So I never shied away from the idea that you have to invest to get, but the idea is to do it efficiently and to minimize costs.
Can I ask you a question now, building on?
Yes.
Like, what do you think? Like, how can we help all our communities, all the advocates around the world? Because quite often, I still have the feeling, if you are particularly in cancer care advocate, you always feel like I have to ask for something. I'm begging for something.
Yes.
I'm not getting hurt. So that what you just said, sort of like going in there with a level of confidence and actually, look, I'm not coming to you actually with a problem alone, because I can tell you, if you solve for cancer, and we know that, if you solve for cancer care, you solve for non-communicable diseases. Because it's not isolated around that. Like we know if you approve, and the example in Kenya, it's the best example. Once you solve or have a baseline for quality cancer care, you also notice you can address diabetes, hypertension, like all those big, that impact all the populations. So how can we better work together and help also those advocates going in there with more confidence?
Yeah, I think so. I think certainly in our experience in Jordan, when we first started, I think owning the issue at heart, we didn't just sit passively waiting for help. That was key. We felt, we knew better what the gaps, we knew also the challenges, but we also knew better the opportunities. And we worked on a plan and we focused. I think sometimes it becomes so overwhelming when you want to fix everything all at once. And, like you said before, we are playing catch up. I mean, high-income countries did go through the trial and tribulations that we are going through now. There's a catch-up of about 50 years, right? And certainly in Africa, shall we say, because of the whole system of global donor behavior that actually just focused on infectious disease, that's why these countries never invested for cancer, right? Not having the infrastructure, not having the human resources, and so on and so forth. So they are having to play catch up. And we have to really talk about the role of global giving, where, it did direct where the money should go. So many countries would only do thing, the global donors would come in with their own idea, and then the country itself would scurry around to make a program so that they can get the money. And these global donors they didn't always like to fall in line and work on one plan. Everybody wanted to do their own thing. And it was always thought of as a short-term relationship, quick fix. We have to show that we've given the money. We have a little KPI here and there, and off they go. So it's not just the advocates and the countries, but also the global donation system has to change. Like you did, like Roche, you went into Tbilisi, you saw City Cancer Challenge, you saw an executive committee all working on one plan. You didn't go and do your own thing. You actually joined this one plan and this one executive managerial structure for that country. And that's why it worked. But so often they come with their own plan. And I've said it in so many other podcasts. When we started to fix our cancer center, we knew we had to first focus on fixing treatment, because we knew that if we don't fix treatment, nobody would listen to us on whether early detection, screening, or whatever, because they never saw people survive. So when we started doing it, and we knew that's the resources we had, and that's where our first goal, we called it the key opener, that's going to open up for everything else. And I remember we got a fantastic organization for breast cancer. It's a global organization with great intentions. They came to us and said, guys, let's do screening for breast cancer. And we said, no, Michael. And I remember their shock and horror. How can you say no? We said, it's not the right time for us now. First, we want to fix treatment. And then people will start to listen to us that they can actually survive breast cancer. We're not going to tell them to screen and find out that they have breast cancer when there is nowhere else to go or get treatment. So I think it's a mixture of many things. But, this is an amazing conversation, Michael, and it leads me, all these successful partnerships you've had, whether in Kenya, in Rwanda, in Tbilisi, and I'm sure others. What is a perfect partnership look like when it works well? What's your perfect client if you had a magic wand?
So I have to laugh a little bit because I really fundamentally believe the perfect partnership does not exist.
Okay.
Not in
good.
a professional context, not in private context.
Yes.
Based on my experience. I think what constitutes a really good one is, first of all, a mutual respect.
Yes.
I really think it starts with acknowledging. It's acknowledging is, I cannot do it alone. And I know that sounds very trivial, but that's really fundamentally a problem. Because a lot of public-private partnerships, because we talk about public partnerships for decades right now.
Yes.
But if I look at it at global scale, it's a single-digit percentage of successful partnerships. And why is it so? Because the private sector thinks we have the solution, and the policymaker thinks it's our job to develop the solution. So the first hurdle to overcome is, and I sometimes make a joke. I say look, I'm operating way more often in ecosystems than in ecosystems. So the first step is leave your ecosystem.
Yes.
An element of humbleness and accept, yes, you have something to contribute and you do, but you cannot do it alone.
Yes.
So that's really for me one. Second thing is really then what you said is use the business tool that are out there, and can you both align on, or 3 or 4, whoever our partners are, can you align on actually what is the problem that we're trying to solve for? And can you give me an articulation once we solved it? What does the world look like? What does the world look like?
Yes.
And I'm coming back to be very clear on what do we want to achieve? Because in the absence of not being clear what you want to achieve, I can guarantee you're going to swirl around how to get there and you will end up nowhere around it. So it's really this element of clarity. And a lot of people were talking about like, okay, like you need to trust. You need to build trust. I have a different concept. My concept have to come back to my grandmother. Also, one of her principles was, I'm going to start with trust right from the get-go. You don't need to earn my trust. I trust you as long as you do not give me a reason to no longer trust you.
Oh, I love that.
But then it's gone. But I'm not going to wasting any time in trust building, because you should trust me in the beginning and hold me accountable.
Yes.
So don't wait, so really hold each other accountable, and then share what is working well, but also share what is not working well. Don't wait till it fails, like nothing under the carpet, just be transparent. So it's basically, for me, it's actually clarity on what do we want to achieve, sort of like, and actually transparency around it. That for me would be the two key ingredients.
Fantastic.
All the other stuff, we can find out, we can figure out along the way, and we will always find solutions.
Fantastic.
Yeah.
And Michael, you've I saw in your career journey, you've worked not only in low-income countries, but also in health systems like Austria and Germany, countries we often think as having it all sorted. But access isn't just a low-income issue, is it? What kind of challenges these systems have?
So it's not actually, those three big challenges: the delayed diagnosis, inequitable access, to a lesser extent, in all fairness, it's to a lesser extent financial toxicity. But a big problem, so like the country where I'm coming from, so I come from a small village, beautiful, but a little bit in the middle of nowhere. And I had my aunt, she was diagnosed with lung cancer, stage 3 lung cancer at the age of 51. But before she got the diagnosis, she went the first time to a doctor at the age of 47, and she was treated as an asthma patient. And because the doctor told her she's an asthma patient, and she comes from so I'm coming from this low social setting. You do not argue, you do not debate with your doctor, right? You accept around it. So we have an issue in all those highly developed countries with your level of education does influence the treatment that you're getting. It's not all equal. It's not all accessible around it. And then we're also facing the same issues of having an aging society. We don't have the facilities anymore for a rapidly aging society. And it's not only cancer care, there are other disease areas out there like Alzheimer's where we are not prepared at all. We have this shortage of healthcare workers also sort of like in our settings. So, and I think actually there is a lot of, because you always speak about low-income countries can learn from high-income countries. I think there's a lot that high-income countries can learn from low-income countries. For example, like the shared example we discussed briefly around this patient navigator. That's a role that does not exist in an Austrian healthcare system. But I can tell you, it would be super needed and super helpful.
Yeah, there's no perfect world out there, like you said, the same as no perfect partnerships, shall we say. Shifting gears again, you've spoken about global antimicrobial resistance, a topic that I'm super interested in, and I'm very upset it's not yet taking front page news yet. The fact that given that the new goal now is to not overuse antibiotics, to use less and less, means that pharmaceuticals are less inclined to produce new antibiotics or innovate on new ones. Yet it is such an important issue that needs to be tackled. I'm so glad you are speaking a lot about this, but you also have suggested very interesting, innovative solutions for helping the market. Can you tell our viewers about that?
Yeah. So I have to do a little bit of travel back in time journey. So if you look at the 1990s, we didn't have this issue, right? So we had a lot of companies were in research for new antibiotics around that. What what then happened, like in the 2000s around it, so governments then started to introducing referencing prices from one country to another. Every government wanted to pay the lowest price. They implemented all those systems. And then actually, so antibiotics, you want to have them, but you don't want to use them.
Yes.
Because normally, like where you make sort of like the revenue or the money as a pharmaceutical companies, you're developing the drug and then you generate your revenue by the number of prescriptions. But in antibiotics, it's actually the opposite, because you want to reserve them for the really, really cases where you kind of like need them. And this is where this model is a little bit broken. So what actually we are debating now with governments, literally around the world, there is starting a little bit of awareness, understanding, and like everyone who unfortunately has a cancer patient in the family, we all know antibiotics are vital for the success of a cancer therapy. Like if you go through chemo, it should be right next to you. Need it.
Yes.
Right? It's around that. So one element would be, first example, really doing a public-private partnership when it comes to research and development. Sort of like, which is kind of like called like a push incentive, which means is you really intensivize, because hardly any company will take the risk anymore going into this highly complex research and development. And here's the thing, it's super, super risky. And it's so risky because, even if you have an antibiotics, and we have examples where small biotechs developed an antibiotics, it was approved by the FDA, by the American Regulatory Authority, and after that, the companies went bankrupt.
Oh.
Because no one wanted to produce it, because there was no one who would pay for it. So we also need a totally different payment model. And there's one interesting experiment at the moment in UK, which they call a subscription model, where you would de-link the price or the money you get for a highly innovative antibiotic from the number of the patients treated. So some would call it a Netflix model. You actually pay a certain fee, an amount, and you actually pay it for, in case when you need it, you will have it and you get access to it around it. And that's a model we are actually proposing for a lot of country, actually for every country around the world.
And is it getting traction in the UK? They are going for it?
So in the UK, they are going for it. And we're also sort of like starting to collect the evidence around, does this model work? And like in Europe, for example, there's also the European, they look at the European pharma law, where they want to sort of like put out their new laws for how regulating certain aspects. And one of them is actually around AMR. And we will see if this will also be covered in this new regulation. But I agree with you, we need and we cannot wait another 5 years.
No, it's too important an issue. Absolutely. Yeah. And you're going back to how you use digital tools in Rwanda to fix reducing the time between diagnosis and treatment. What other opportunities beyond medicine do you see AI and technology helping improve access?
So I think the first step, which is really right at the beginning, but it will benefit a lot of patients, is AI tremendously accelerates how we can do research and development, which is sometimes underestimated. Like we can use now those big, large language models to analyze a magnitude of data. So there it's also super helpful, because that means we can be fast in developing medicines and they can then reach patients faster. I think what is a huge future benefit of artificial intelligence or the AI or digital tools is actually that it can help to bridge the care gap that we have, because we do not have enough human resources. Digital pathology would be one of those topics, right? You won't have, particularly Africa or other low resource settings, you won't have a pathologist around the corner. But you actually can create a system where it goes digital, where a doctor sitting in another country can sort of like look at the data and can really accelerate sort of like diagnosis, and can with that also accelerate access. So everything where it's about diagnosis, this is probably where we're going to see the next big wave in digital solutions.
Yeah. And like for reading mammograms and so on and so forth. Yeah, that's amazing. If you were to sit at a dinner, and next to you there is the health minister on one side and the finance minister on the other side, what would you say to them?
I would say to them, I would actually ask them a question. I would ask them, how often are you guys, or you guys or girls, how often are you two speaking with each other?
Wow, that's such a smart answer.
That would
Yes.
be my first question. And do you understand what you each other are doing?
Yes. Yes. I love this answer. I think this should be a quote, one of your quotes. Aside from the ecosystem that you spoke about, this really struck a chord with me. Well, Michael, before I wind down our conversation, tell us how you unwind from all of this work and travel and so on and so forth. What do you do? And I heard that you also have a Jack Russell called Monty, whom you absolutely adore. Tell us,
Yeah.
how long have you had him and what do you do in your spare time?
So guilty. So first of all is unwinding. I really love what I'm doing. And I love
Yes.
what I'm doing because it's such a privilege to work with brilliant people like you and other people around the world. So there's not a single day, even if it's super stressful, where I'm not aware that I'm very privileged and grateful. Sort of like for what I'm doing in being able to make a contribution. So actually my dog happened during COVID, but it's not a classic COVID dog. So I had a dog before. And actually my intention was I want to have a dog for sort of like going out for running and being more active. Turns out, and I was like classic, I said like, I just had a look at the puppy.
Yeah.
You know, I said like, I'm not going to get a dog. I just had a look at the puppy. Yes. Stupid me. I saw the puppy. I take him home. So turns out I have the laziest Jack Russells in the history of Jack Russell.
So no exercise for you.
No exercise, but I also picked up during COVID yoga, which really helps me winding down. So again, I have to come back to my grandmother. Another principle of her was stop whining, be disciplined.
Yes.
There's no reason for complaint. For I start every morning at 6 o'clock with a yoga session.
Fantastic.
Regardless where I am, I also travel with a yoga mat. And if I do it in Basel, where I'm based right now, I'm actually doing yoga with my dog. And that's my unwinding. I just need half an hour, quietness, sort of like with this yoga thing, and then I'm prepared for whatever is coming my way.
Fantastic. Well, you know something? I really wish I met your grandmother. She sounds such an amazing, wise, loving person. I wish I met her, honestly. You should write a book about your grandma and how much she influenced you. I really think so. Thank you so much for giving us a snapshot of what it takes to help get access and treatment for those who need it most. And it does take a determined and fair person and a human person such as yourself who believes so much in equity to be able to get that done. And I really feel that talking to you, Michael. And I'm sure my viewers learned a lot more about not only the challenges of achieving access, but also the practical solutions that exist there for those who want to find them. They are there for those who want to implement them. Thank you so much for joining my Global Health Dialogues podcast. It has been an absolute pleasure. Thank you so much.
Thank you. If I can say just one more thing,
yes,
closing
please.
in, it was an absolute privilege, and like you truly inspire me in the work that you are doing. And I cannot end this without saying people, it's not doom and gloom. There's a lot of hope out there. We have so many smart people around the world advocating for the same thing. We have more tools and more solutions than we ever had before. We just need to align each other and raising our voice and become stronger together.
Absolutely. What a way to close our conversation. Thank you again, Michael. And I really look forward to seeing you again in person. Take care.